So hello dear everyone, we're back again to our lectures about some challenging topics. So we got a lot of requests about tackling the topic of cardiac amyloidosis. So let's give an overview for cardiac amyloidosis and the new medications and treatment available nowadays for this grave and lethal disease. This topic will be discussed in 3 lectures. So this is the first one of the 3 lectures. So let's overview quickly cardiac amyloidosis and see where's the problem and what's going on here. So this is part one. What's the problem in cardiac amyloidosis? So let me tell you something here. So first of all, we do have a normal plasma protein in our body, which is called transthyretin. Transthyretin has a specific function in our body, and the function of transthyretin is to transport and transfer the thyroxine hormone and the retinol, which is vitamin A, the active form, throughout our body. So actually, our liver produces transthyretin normally. This is the function of the liver. And transthyretin normally has a specific morphological appearance. It is formed of a tetramer. Tetramer means 4 parts or 4 portions, arranged in a specific way, let's say like a letter X, with the 4 limbs of the letter X representing the 4 portions of this transthyretin in the normal form. The normal transthyretin can be transported through the plasma and through the blood in a normal way and does not deposit anywhere because the 4 tetramers or the 4 monomers of this tetramer are attached together in the middle portion by the charges and the negative and the positive and the attraction charges between the monomers. The problem in amyloidosis is that this central part, which puts the 4 monomers together as the regular shaped tetramer, this part is unstable. And when it becomes unstable, the tetramer is broken into the individual monomers. So you have a lot of individual monomers walking through the bloodstream. So those individual monomers are aggregating together in another form other than the regular normal form, the normal physiological form. They aggregate together in a form called misfolding, and they make what is known as the fibril, the amyloid fibril. This amyloid fibril deposits in the organs and causes damage. So we need to understand that transthyretin is a normal plasma protein in our body, and it is produced by the liver, and it has a normal function in our body, which is to transport the thyroxine and the retinol. The problem in amyloidosis, which we are going to speak about and discuss today, this form of amyloidosis, is that the central part that collecting the 4 monomers as one tetramer is unstable. And this instability leads that the monomers are then detached from the tetramer and they are circulating in the blood. And then those monomers are misfolded and aggregating together to form the amyloid fibril. And this amyloid fibril is deposited in the organs, which causes the pathophysiological form of amyloidosis. Amyloidosis has several genetic types, maybe like 7 or even more. And from those, all of those phenotypes or amyloidosis subtypes, we are focusing on 2 types, which represent more than 98% of all the amyloidosis. One of them is a hematological disease, which we call the amyloid light chain or AL amyloidosis. And the other one is what we call the ATTR amyloidosis, which is going to affect the heart, amyloid transthyretin type. And this is the amyloid transthyretin type is the one that we as cardiologists will be involved in treating it, because the immunoglobulin light chain type amyloidosis, or the AL type, is a hematological disease. Let's put some also basic data here. So you have the plasma cells, which are part of your immune system. Those plasma cells are responsible to produce antibodies when you are attacked by when you are attacked by a foreign bacteria or something. So when you get those antibodies in a big amount, because the plasma cell are having what's known as plasma cell dyscrasias, or crazy plasma cells, or malignant plasma cells in the disease of multiple myeloma, your body is producing a lot of antibodies in an abnormal shape, also in an abnormal physiological function. Those antibodies are composed of light chain and heavy chain. The light chain accumulates and deposits as amyloid fibrils. The problem with the AL amyloidosis is that it is lethal within 6 months to 1 year. So it is a deadly disease. So we need to know how to diagnose it or how to suspect it and send it to the hematologist as soon as possible. So the hematologist will start the chemotherapy necessary for multiple myeloma and treat this case before the patient dies. Other than this AL type, or immunoglobulin light chain type, you have the ATTR type, which we are concerned as cardiologists to treat. The ATTR type, regarding that it has two subtypes, the wild type, where the liver produces a lot of amyloid material, and the hereditary type, which runs through families. I don't focus whether the patient has a wild type or a hereditary type regarding the diagnosis and the medication, because the medication that we will discuss in the third part, which is newly available now for cardiac amyloidosis, is actually working against both types of ATTR as a specific medication, and it is working with comparable results in both situations. But the importance here is that if you get a patient with a hereditary ATTR amyloidosis, you can do genetic study for his family to detect those individuals that are liable for this disease. Because as we will discuss in part 3, which is the part involved with the medication and treatment, we will know that the earlier you start the medication before a lot of amyloid material are developed and before a lot of amyloid material are deposited in the heart of the patient before developing NIHA class 3 and 4 heart failure, the patient that you detect and treat early are those patients which will get the maximum survival benefit and the maximum symptomatology benefit as well. As I told you, the pathophysiology, this is the image showing it. The liver produces the transthyretin, which say it has 4 limbs or a tetramer formed of 4 monomers. And those monomers are like an X shape, and they are naturally connected in the middle by the charges available at the end of each monomer. When it's dissociated, which we call here the rate limiting step of amyloidosis, where the transthyretin is not stable and it is broken into the 4 monomers, those 4 monomers just wander around in the bloodstream and get together to form an amyloid fibril. The amyloid fibril does not look like the normal tetramer, and the amyloid fibril does not behave like the normal tetramer. So the amyloid fibril actually deposits in the heart and causes cardiomyopathy and heart failure of our interest, and also deposits in many other organs, including the liver itself, including the peripheral nerves, peripheral neuropathy, including the eye, including several other parts of the body. The diagnostic challenges here are high. Why are the diagnostic challenges high? Because number one, you might not get the patient here. So actually, as a cardiac patient presenting by cardiac amyloidosis, the patient with cardiac amyloidosis is initially misdiagnosed. Why? Because the patient presented by symptoms and signs of what looks like heart failure with preserved ejection fraction. The problem with the amyloid material is deposited in the wall of the ventricles, and this causes stiffening of the heart. This causes diastolic dysfunction, elevated LV pressures, but the LV function can be preserved. So when you look at this patient by an echocardiogram, for instance, you can find a patient with normal LV systolic function, but the problem, of course, is diastolic dysfunction. Not only that, let's say that one of every six of the patient with aortic stenosis, meaning around 15% of those patients, can actually have cardiac amyloidosis. And those patients, whether referred to perform the surgical aortic valve replacement or the TAVI replacement using the transcatheter aortic valve implantation, those patients will die and will not improve symptomatically because of the initial pathology of cardiac amyloidosis. You can detect the aortic stenosis and treat it, and then you not detect the cardiac amyloidosis, so you end up by a symptomatic patient and having a high mortality rate after performing an expensive procedure for him. The patients sometimes are misdiagnosed as hypertrophic cardiomyopathy and sometimes are diagnosed as ischemic heart disease. The problem of those patients is that you give those patients, which already have peripheral neuropathy, hypotension, fatigue, and dyspnea, the regular heart failure medications, which reduce the cardiac output and improve the afterload and reduce the afterload, you will get a patient that will be deteriorating on the heart failure medication. And this leads to the diagnostic delay because in a survey of the patients with ATTR cardiac amyloidosis, nearly 20% of the patients visited 5 different physicians before reaching a definitive diagnosis. And the time to diagnosis was 6 years nearly for detecting the ATTR, whether it was the wild type or whether it was the hereditary type. So it is important actually to know the symptoms and the signs and what are the red flags for early diagnosis. The other problem is that the patient might not present to the cardiologist. If the patient has peripheral neuropathy, he will present to the neurologist. If the patient has heart failure, he will present to the cardiologist. If the patient has a biceps tendon rupture, he will refer to the orthopedic surgeon. If the patient presents by symptoms of autonomic dysfunction like diarrhea, constipation, so on, he will refer to a gastroenterologist. So sometimes the patient is not initially referred to a cardiologist, and this also puts challenges and increases the timing and delay of the diagnosis of cardiac amyloidosis properly. But this also means that you need a multidisciplinary approach, including many specialties with you. The orthopedic surgeon, the neurologist, of course, the hematologist, which is the first step, and we will show in part 2 regarding the diagnosis. We will show that the hematological test at the beginning of the suspicion is very important because if you detect a patient with the AL type or amyloid light chain type, you refer him to the hematologist, he will receive medication, and this will save his life because if this patient is not treated properly or detected, he will die within 6 months to 1 year. Both types, whether AL type or whether ATTR type, have similar manifestations because you get the amyloid material which is deposited. And those are the manifestations in general, of course, heart failure, patient intolerance to the standard therapy of heart failure, sometimes cardiac arrhythmias, atrial fibrillation, aortic stenosis. I told you that 1 in 6 of the patients with aortic stenosis was found to have cardiac amyloidosis. You have a thickened left ventricle by the echo, and you suspect to see a big voltage on the ECG, but you get a low voltage on the ECG. You can refer to the ophthalmologist by glaucoma, vitreous opacity, nephrologist by renal impairment, nephrotic syndrome. He can refer to the neurologist by autonomic neuropathy, unexplained weight loss, orthostatic hypotension, peripheral motor dysfunction, and of course to the orthopedics by the tendon rupture or the bilateral carpal tunnel syndrome or lumbar or spinal stenosis. We will discuss the diagnostic approach in the second part. Thank you so much.